Patients should be checked for complex karyotype prior to initiating therapy. So from my perspective, as we don't have any data that indicates, at the moment at least, that we should start treatment when patients are asymptomatic. So a CLL patient with first diagnosis of CLL and who doesn't have any symptoms, any complaints, he doesn't need therapy, particularly if he has a normal blood count. So this is also defined in the RWCLL guidelines. No treatment for these patients, just watch and wait strategy, because no treatment has shown any survival benefit for those patients when they are treated, irrespective of their symptoms. And so we would suggest that patients who become once they require treatment, then we should check for complex karyotype, because then it has direct therapeutical implications. And one should do that along with the whole diagnostic workup. So IGHV status, TP53 status, and complex karyotype should be done before we start treatment, and then it can guide us to start treatment and to choose the treatment. And another time point might be as well, although we don't have sufficient data for that at this stage, to check once the patient relapses. So if we've completed treatment, the patient has a relapse, and once he requires treatment for his relapse because he has again symptoms, the blood count has moved, then we should again check for it in case the patient didn't have it before. If he already has complex karyotype, it's very unlikely that this has changed, and therefore this would be also a good time point to do the analysis.